Ciao mondo, hello world, hola mundo, hello mon. We are here today taking a cappuccino in Riyadh at the Critical Care Nephrology Symposium with Dr. Brophy and Dr. Eyadhy, head of the Pediatric ICU in the center of Riyadh, discussing about the risk of fluid overload in the pediatric ICU population. So Dr. Eyadhy, can you tell us a little bit about fluid overload?
Okay, let me start by welcoming you to Riyadh. It was a pleasure to having you here in Riyadh in this symposium. And let me start the discussion by maybe taking the opinion about a patient who was admitted over the weekend. He's a 2.5-month-old baby who came with a neuroblastoma post-biopsy. And he came to us with severe systemic inflammatory response, with sepsis-like picture, and almost hemodynamic instability. And he started to have significant fluid accumulation secondary to fluid boluses, as well as secondary to poor urine output and what could be an acute kidney injury. So his creatinine was rising up, and we're trying to monitor him conservatively, but we start to see more fluid overload that we can manage partially with diuretics. But we start to think about, shall we do early dialysis for him, at least for the fluid removal, especially in the context of sepsis or not.
So Patrick, would you have started renal replacement therapy in this baby?
Well, I think there's some good evidence to support early initiation of CRRT in a situation like this, and I would probably use CRRT in this situation given the sepsis-like picture. You know, the current evidence that we have for fluid overload and mortality comes out predominantly out of the pediatric literature, and it's pretty clear that once patients get over 20% fluid overloaded, their mortality rate rises. So I think you've had a really good start to it because you started to consider it early, and you're trying to bridge through the initial septic period, which is important because you do have a leak. But in situations like that, I would certainly consider starting dialysis early, not necessarily to take fluid off of the patient, but to prevent more fluid accumulation. And I think that would be extremely helpful in this case.
So Dr. Eyadhy, did you start actually CRRT?
Not yet, given the context of a stable ventilation requirement. So he's in low setting, and he started to have some hemodynamic improvement, and his urine output is still ongoing. And when we counted his almost fluid overload, it will be less than 10% still. So maybe we'll give him 1 or 2 days to see further response to the conservative management. But I think if we go beyond that, we'll significantly consider the renal replacement therapy for some fluid management.
Okay, so we have cleared today, one, that the fluid overload is one of the major triggers for renal replacement therapy. It is a risk factor for mortality in neonates and infants, and the concept of early initiation may be relative considering the different options in the patients and the evolving situation of the patient. With this, I thank you very much for joining today, Cappuccino, and I wish you a wonderful day from Riyadh.
Excellent.